Hi everyone, today we're going to learn about respiratory assessments for pediatrics. This would normally be part of your head to toe assessment. However, we're just going to focus on the respiratory assessment today. The things we're going to look at today, we're going to look at some key points to follow throughout your entire assessment, but specifically your respiratory assessment. And then the 3 points of your respiratory assessment that we're going to look at are look, listen, and feel. And that's the order that you're going to go in for the assessment as well. We're going to do a brief tools of respiratory that you might use either for assessment or treatment. Then we're going to do a brief example. You'll hear a lot of the things that I will go through in this PowerPoint repeated in the example. And then final tips and takeaways. So your key points to remember throughout your assessment is that you're always going to interact with the parent first. Children often take cues from their parent. So you're going to interact with the parent. You're going to make sure that they feel comfortable with you, thus the child will start feeling comfortable with you. You're going to play with the child, age appropriate, of course, and you're going to sometimes during the play, especially with younger children, you may introduce tools, which you'll see in the example. You're going to get all your health history from the parent, and which I don't show a great in the example, the health history, just because Declan was actually sick the day that I used him for an example. So, but you would normally go through a health history and do all those steps. And then look, listen, and feel. That's the order that you're going to go in. The one thing that I like people to remember is that there are a lot of things that we normally see as convenient for us as caregivers or clinicians. But for children, you're going to want to make sure their comfort is most important over your convenience, mainly because if they are uncomfortable or crying or fighting you, you're not going to be able to get a true assessment. Their respirations, their heart rate, their motion, their behavior, all of that is going to be not a true assessment. It's going to be a scared assessment, which is going to look different than a normal assessment. So comfort over your convenience. So first we're going to do look. This is going to be somewhat done while you're talking with parent, and you're going to observe. You're going to let the child play with stethoscope, especially if they're younger, while you talk to mom or parent or grandma or whoever brought them in. You're going to observe the breath ratio. Normal ratios for breathing is 1 to 2. So that means if you took 10 seconds to breathe in, you're going to take 20 seconds to breathe out. Now that's terrible respirations, but it's a good example for numbers. And so you're going to make sure that that ratio is there, that 1 to 2 for inspiration to expiration. You're going to count the respirations. You're going to observe the rate and observe the rhythm and the depth, whether it be shallow or deep or normal or medium. One of the reasons that I say rate, rhythm, and depth is because sometimes you will have different rhythms of breathing. So you could have bradypnea, where your breaths are below the breaths per minute, and you'll see in that graph there the different ages in the normal breaths per minute. Tachypnea, where your breaths are faster than normal. If you have a patient who's afraid, you very well may have tachypnea on a scared assessment versus a normal assessment. So sometimes in that talking with mom or talking with whoever brought child in, you can observe their respirations before you ever interact with child, and that will be a more normative respiration count. Then you have Cheyne-Stokes, I always say it wrong, Cheyne-Stokes, where you have deep and then shallow and then followed by apnea. So and that would be a different pattern. Concussmal, which is fast and deep and labored, and that's usually fearful, but sometimes that's significant respiratory distress. And then you have a mix of both of those, which is irregular patterns of breathing followed by patterns of apnea, and that is another sign of respiratory distress. While you're in your observation phase, you're also going to observe for secretions: small, moderate, copious, which is your smallest to greatest. And then you're going to also look at consistency, whether it be thick, moderate, or thin. You're going to look at color, whether it be clear, white, yellow, green, brown, red. And that color can sometimes tell you a little bit of what's going on. It can't always tell for sure what's going on, but yellow or green are more indicative of bacterial infections. Brown or red are more indicative of bleeding somewhere, usually in the nasal passage. And you may want to do a part of your head, ear, nose, and throat would be looking at that, but remember that your mouth and your nose are still part of your respiratory system. So you may have to do that evaluation um, kind of in conjunction with your respiratory, but not true respiratory. It's part of your head to toe. It's why your head to toe is important um, for your other factors in your assessment. And then you're also going to observe the work of breathing, um, which is usually observed by position, but sometimes just um, accessory muscles that are being used. If you think about it, if you go run a lot and you're really taking deep breaths and you lean over like this and you're using your arms to support, sorry about that, arms to support your breathing. That would be what we call tripod. Tripod can look like a couple of different things. It can, even if you lean back to breathe and you're using your arms backwards, it's rare, but happens. But usually it's leaning forward. Sometimes kids will lean, a lot of times people will lean on things. Adults will lean on bedside tables or things like that, or on their knees. Um, Kids will also lean on their knees. Sometimes they'll just let their arms flow and lean forward. Um, and then the other thing that's part of your respiratory observation is their skin color and their trachea placement. So if you're doing a physical assessment, you can do this where you put your fingers here and trace the trachea to make sure, especially if you have an intubated patient or someone who's unconscious. But if you're just looking, sometimes you can just look. Now, if you have a particularly well-nourished child, you may still have to feel, but that wouldn't be part of your observation. That would be part of your palpation after auscultation, that part of the feel phase. But look at skin color. If you have, blue or purple or just off-colored fingers or toes, then you know that there's probably something respiratory going on or that the child is very cold. And that happens in exam rooms. So all of those things would be important to observe or to look. Lastly, we're gonna, or not lastly, middle ground here. You're gonna look, you're gonna listen, which is gonna be after you've introduced your tools to the patient, after you know that they're comfortable, mainly because again, if they're not breathing normally, you're not gonna get a true auscultation. So you're gonna make sure child is comfortable and calm. You're likely gonna, especially for younger children, listen to them while they're sitting on their patient's lap. Sitting on their parent's lap, excuse me. The patient is sitting on their parent's lap. That is going to be their most comfortable. You're a stranger and you're coming at them with a strange device. They want to feel comforted. Often they will go to whoever brought them in to them for comfort. Then you're going to show them what a deep breath looks like, especially for young children. Maybe have parent example. You're going to listen with your stethoscope. You're going to listen with your diaphragm of your stethoscope. You may, for very young children or infants, have to get a pediatric sized stethoscope, which is much smaller, mostly because our normal stethoscopes are sized for that of an adult chest, but a child's chest is much smaller. So you're not going to be able to listen in the correct places to get the correct sounds. Now, this might be more for cardiac, but even for respiratory, sometimes pediatric stethoscopes are useful for small children. And then you're going to use the same places, if you will, as adults. So still your places in the front and the back. But for children, because their heart takes up a little more space inside their chest cavity, you might have to listen more laterally. And you might have to listen above the clavicle. We're going to listen to a couple of examples here. I do want to go through these different types of breath sounds that you might experience. You're gonna, stridor and wheezes can sound very similar, but also very different. The reason why is that both wheezes and stridor are an obstruction or narrowing of the airway. So you're going to have some similarities between them. Stridor, if you think about it, is just a very severe wheeze. Whenever I think of Strider, I always think of the penguin toy from Toy Story. I think his name was Mr. Wheezy. Not 100% on that, but I think that it was. And for me, every time he talked, I always heard Strider. You could say sometimes it's a really severe wheeze, but for me, it was always Strider. And then wheeze is going to be, they say it's a musical. I think of it as if you blow over a straw. It's kind of that wind chime kind of a thing. Um, Wind chime being a hand flute, not necessarily the ding, 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 ding wind chime. And then we're going to do crackles. Crackles is like where there's fluid, right? So if you think of a Slurpee cup from a gas station, or if you take your hair, mine is up today, so it's not a great example, but if you take your hair and when you inspire, you rub it between your fingers, that hair rubbing against each other, again, it doesn't work as well with tiny bits of hair, but if you do it with a larger chunk of hair, that is a little bit what crackles sound like. It is intermittent, it's not all the time, and it's with breath sounds. It's not musical, and usually it's kind of brief. A lot of times you can hear it in lower basses, but sometimes you can hear crackles or coarse sounds up in the upper parts of the respiratory tract. Um, and then friction rub. They say it's a leathery sound. Sometimes I think of it as the sound of a swing set when you have that creaking sound with movement, because that movement in and out, that swing, that's more of a wheeze, but that movement is what makes the rub. So if they're not breathing, you're not going to hear friction because they're not rubbing. But if you are, it's that of the different organs against each other. So we're going to first listen to normal breath sounds. And when you're listening, positioning, you're going to want to hear a full inspiration and expiration at each location that you're listening at. The importance of this is that you may have to listen for double the amount of breath sounds than you're truly on the chest for. Because if you do inspiration, the patient's still going to breathe. I didn't get a full inspiration. I got half of inspiration and an expiration. So you may have to listen for another inspiration, expiration at that site. And then this is your Strider. You hear that sounds like something stuck in my throat. That's usually when you hear Strider. That musical on inspiration or expiration. Crackles, this recording has a strange mechanical buzz in it. It's not that buzz, it's that sound that comes a little bit in it, but I'll point it out for you. So it sounds weird, but it's almost that like at the end of a Slurpee, if you will. And then your friction rub. Those are your examples. If you guys have any questions, let me know. The last step is going to be your feel, your palpation and percussion. Now you're going to not necessarily do palpation and percussion, especially for younger children, except for very specific things. You may palpate lymph nodes to see if there are lymph nodes swollen, especially if they come in with sore throat or things like that, or ear pain and respiratory. Sometimes that happens. But you wouldn't necessarily do your tactile fremitus or your inspiration expiration where you watch the hands move to make sure that the inhalation is equal, right? Mostly because that movement, especially for small bodies, is not going to be reliable to know if it is a true equality. Also, it's very difficult to give instructions to especially younger children and have it be obeyed in the way that it should be. Like if you tell a young child to say 99 and they can't say 9, it's not really going to work. So the other thing that, so age appropriate palpation and percussion, symptom appropriate palpation. And then the other thing is you're always going to explain everything to the patient if you have an older child, but to the parent if you have a younger child. Sometimes you may demonstrate on teddy bear or doll or parent. You'll see this in the example. And then for palpation, again, if you're palpating lymph nodes, that's a little bit different. But if you're palpating chest, it's for ages 5 and older. For percussion, again, 5 and older, you're going to want to explain it. You may have to, and explaining by that, I mean, don't just say, hey, and now I'm going to use percussion on your lungs. 5-year-old is never going to understand what that is. But if you say, I'm going to make your chest sound like drums, do you want me to show you? And then you show them on yourself. Oh, that sounds kind of like a drum. Mom, do you mind if or Dad, do you mind if I show on you? May I show on your chest? You sound like a drum. It will be much easier to get through that. Now, obviously for a teenager, you don't want to do that because they're just going to be insulted. And then again, tactile fremitus, equal sides with noise, usually using 99. The last thing that is part of palpation is finding crepitus. So crepitus is, once you see it, you will know it forever. Crepitus is where air bubbles form under the subcutaneous skin, but it is because there is an air leak within the chest and it's leaking into the chest and it's coming to the skin. A lot of times people will explain it like bubble wrap or that small packing foam, that's that thin layer of white foam that you'll find that's packed with your boxes and things like that. Kind of looks like that, but on skin. Some people will say that it looks like foam underneath the skin or bubbles or froth, but it's under the skin. And then when you touch it, it will depress kind of like edema, but much faster, and it will pop, it will crackle. So it sounds like Rice Krispies when you pour milk in, but it feels kind of like bubble wrap or foam. Again, once you see it, you will look at it and you will go, hey, I know what that is. That, I think, yeah, no, that is crepitus. Yep. I I don't know that I have any other words to describe it other than the ways that I've heard it described. It's not quite like that, but it is like that at the same time. And you will know it and you will say, yeah, I know it forever. The most important time to assess for crepitus would be with your intubated patients, mainly because that means that your settings for your intubation are probably a little high and you might be over respirating them. And so it's going to be a little bit more, you might need to decrease your settings. And you would work with a respiratory therapist and see that. Or it might mean that they have a leak that needs fixing or some kind of other treatment. There's a lot that goes on with that, but it would definitely something to report pretty quickly to a physician and to a respiratory therapist. You would want to pull in your team to address that. Last, older children assessment treatment and tools. The reason this is for older children is because they have to be able to follow instructions, and that can be really difficult. But you can use a pulse oximeter. Now, I'm not saying that you won't use a pulse oximeter for infants or children in the hospital. You absolutely will. But if you're teaching them to use a pulse oximeter at home, specifically with your asthma patients or your pulmonary fibrosis patients, you teach them to use the pulse oximeter at home. And then your peak flow meters, those are for your asthma patients. Again, this would be something that they use both in the clinical setting and in the at-home setting, especially with asthmatic patients who play sports or do activities. This would be a tool that they use in order to help them assess when to use their inhaler and how well their inhaler is being effective, or maybe even if they're playing sports, they might need to take a break, use their inhaler, let their symptoms calm down, and then go back to the sports. And then the last one that is in this picture here is this metered dose inhaler attachment. So especially children find it difficult to start inhaling before they push their inhaler and then continue the breath. That instruction, that coordination is sometimes really difficult, especially for younger children. This meter dose inhaler attachment allows them to push the button and then inhale. They don't have to start breathing. It helps to control the dose that they're getting and is much easier for them to use than just the inhaler. This is my example that I'm going to play for you guys. My friend Alyssa and her son Declan, and we're going to do just a little introductory.
Maximum
So
volume.
you're going to sit kind of far away. That's totally fine. Say, hey, how are you doing today? Good. Good. Who do we have here? This is Declan. Hi, Declan. How are you feeling today, bud? My friend Alyssa and her son Declan, and we're going to do just a little introductory. So you're going to come in, you're going to sit kind of far away. That's totally fine. You're going to say, hey, how are you guys doing today? Good. Good. And who do we have here? This is Declan. Hi, Declan. How are you feeling today, bud? Feeling a little great. Yeah. There you go, little man. You a treat. So tell me what's been up with Declan. Declan's had a bit of a fever the last couple of days. Yesterday it got up to 102. He's still got a bit of a fever today. Okay. And some congestion. Okay. Has he been coughing? Not too much. Actually, not too much coughing, more just snottiness. Has he been spitting anything out? Has he been slobbering? No. Anything like that? No. So some of the things that you're going to do in the first part of your assessment is just to interact with parent. Let child witness your interaction with parents so they know that you're a safe person. You're actually going to also ask all health history questions of parent. You're going to ask about symptoms. You're going to ask how long symptoms have been. Because he's got respiratory things going on and a fever, you are going to wear a mask because if you're assessing one child and then going to another child, you don't want to bring any respiratory illnesses to one child. To remember throughout, you're always going to look, listen, feel, and comfort over your own convenience. So comfort of child, not necessarily feeling sure of himself. He doesn't have to be a confident child. He just has to be a comfortable child. Reason being, your heart rate, your respiratory, your movements are all going to be different if you're not comfortable. So if he's not comfortable with me, then he's going to act normal than he should be, than I should be assessing. So first of all, you're going to observe him. You're going to see that he's not sitting in tripod position. Anytime anyone has to do more than just their torso of supporting their chest to breathe, that shows that there is some kind of distress. He's doing good little tummy breathing right now. He's not doing any nasal flaring. He's not coughing or anything like that. All of these are just going to be observations. You might move a little bit closer and say, how you doing, bud? How you feeling? Oh, I'm sorry you're feeling crummy. So then you're going to explain to parent, hey, to listen to his chest, I am going to need skin to stethoscope. So if you could just take off his outer top layer for me, that would be great. It's so good. And I so this is something they're going to use. Do you want to look at it? No, it's okay. Do you want Mama to look at it? Sweetie, baby. It's okay, Dad. She's gonna listen to you. So that's okay. You can say, Mom, if you want to go ahead and comfort him whatever way you normally comfort him, then that would be okay. Hey, I'm just gonna listen to you. Just gonna listen to you. Make sure you're not crying. Okay, Mama's here. Yeah, you're okay, little girl. Sometimes it's better to keep the child comfortable if you can go behind and listen from the back, and that's okay. Auscultation is going to be about the same, the child as an adult. If you need to for a really small, you like, ooh, deep, good job. Deep breath. Good mama. Right. Deep breath. So anytime you have cries or anything like that, you can try and make the child more comfortable and just let it soothe. Yeah, that's okay. Okay, good job. Right. Do you want to try and play with your chickens? What? You want to play with your chicken? What does the rooster say? Do we listen to the rooster? And this can get a little bit difficult too. Here, you listen to the rooster. Listen. Oh, that's a little bit. So, so with the child, you would still listen to the number two. So you would listen right, left, right, left, right, right, left. When you're listening to a child, you're going to need to make sure you listen to the outside because their heart is bigger than an adult's heart. So their lungs are pushed a little further laterally than an adult's heart. Hey, can I listen to the chicken? No, it's still too scary. You want to see it? That's going to take a little bit longer than you might normally expect, especially if you have a sick chest, because he's already feeling grumpy. So, when you listen to an older child, you can practice taking deep breaths. Good job. Good job. Down. Oh, you've got a great heart, little man. Good job. Right out here. That's a great breath. Right on the other side. Oh, that's excellent. So this from the back. One of the things you'll need to remember with children is to listen above the mandibular line. Good job. Oh, good. Good job. So for
So for
children,
children,
you're going to
you're
want to
gonna want to
also
listen to
listen
this
axillary.
axillary.
You don't
You don't
necessarily have
necessarily
to
have
listen
to
axillary for
listen to
adults, but you might need to for children. And
and
then
then
not
not
necessarily for
necessarily
somebody
listen to
Declan's age, but if
but
you
if you
were
were
wanting to do palpation for lungs, you would check on the front and you would just push your hands on either side of the sternum. And when he takes a deep breath, you can see if it moves. For Declan, he's a little bit small and he's not super directable, which is that deep breath. You have to actually have that movement of the chest to see that difference. For older kids, you're going to want to model on parent or on doll or on teddy bear before you ever do something to them, just so they have a little bit of experience. And for someone who's already feeling nervous, it might have been better for us to introduce the stethoscope a little bit early on, but that's okay. You go with the flow and make sure child is comfortable. Now he's great. So he just took a little bit extra time because he's feeling a little crummy today. So he does have a little bit of drainage from his nose. That would be part of our look. No coughing or anything like that. His lungs sound clear bilaterally throughout, which is great. And then if you could direct the child, if you could direct the child to tactile preventives and it was appropriate for age, you would do that as well. And then the last thing that you would do with palpation is if they have any crepitus, which is like kind of a Rice Krispie feel. And once you've seen it once, you'll know it forever. And that just means that there's a leak somewhere from their lungs to underneath their skin internally. And that's not good. So Declan doesn't have any of that. He might have a little bit of a cold going on, but other than that, he's doing okay. Special thanks to my friend Alyssa and her son Declan. He is just shy of 2 years, actually, but he is 2 years. So your final tips and takeaway, I've mentioned it several times, but interact with patient first. And the reason why I came in and sat at child's eye level is because a stranger looming over a child and looking down on them is not the most comforting thing. So you're going to have a scared child when you try and do that assessment. And then build that relationship, always get health history from parent, look, listen, feel, comfort of child over convenience of clinician, and your advantageous sounds. So first ask, is this a wheeze? Is this a crackle? Is this a rub? Or is there no sound at all? Sometimes you'll have absent lung sounds, and that's also a concerning finding. And then you can get the severity from there. So if it's a wheezing sound, is this stridor or is this wheezing? Especially if the child is choked on something or you know there's something stuck in the airway, you'll have stridor up in the upper parts of the airway. And you'll have it down low as well, but you'll hear it really clearly in the upper parts. Do you guys have any questions? And then these are my references. All the audios were actually from the Merrick manuals, and they were collected by Colgan. But you can find a lot of really good audio references or audio files on Merrick Manual, both for heart sounds and for lung sounds. And that would be through this link right here. Thank you so much.